For this presentation, we will be discussing Case 3. The clinical notes are as follows. A 52-year-old female patient in the surgical ward is recovering from abdominal surgery. The following specimens were collected: a wound swab, a blood sample, and a nose swab. The wound swab produced a gram-negative rod when the pus was tested and produced a pure culture of E. coli. After the blood sample was incubated for 2 days, a mixed growth of E. coli and B. fragilis was produced. With the nose swab, we were able to isolate Middleton-resistant Staphylococcus aureus.
So, what are surgical wound infections and how are they caused? Well, with any surgery that involves an incision in the skin is prone to a number of infections that may develop within a month after surgery, and this is caused through a number of ways, including inadequate hygiene or bacteria from inside or outside the body moving and spreading onto the site of surgery or the use of infected instruments. While some cases are asymptomatic, these infections can cause fever-like symptoms, vomiting, redness around the wound, draining of pus from the site of surgery, swelling, pain, and bloody diarrhea, which is caused by the toxins damaging the intestines. So, who's at risk? Well, if you are someone who is immunocompromised, have poorly controlled diabetes, and have surgery that lasts over 2 hours, then you are more prone to being exposed to a surgical wound infection. There are 3 levels of infection, including the first level, which is superficial and refers to the bacterium spreading onto the level of skin only. The second level is deep, which is when the bacterium spreads beneath the skin and enters the muscles and other tissues. And 3, organ space, in which the bacterium spreads onto the organ of the surgical site.
Microbiology laboratory workflow. The day we receive the specimens is day 0. In this case, it included the wound and nose swab and blood sample. Culture on agars that can differentiate the species of the bacteria and or selectively identify it. On day 1, we will perform gram stain, catalase, and oxidase tests, read the culture results, and set up extra tests that can help identify the pathogenic organism, such as coagulase, API, and DNase. Set up antibiotic sensitivity tests according to the suspected species, and inform doctor of any possible urgent risks. On day 2, we might be able to determine the pathogenic bacteria from the extra test and get to write a doctor's report, while often cases we would need to do more tests to identify the cause. On day 0, we cultured wound swab on horse blood agar, aerobic and anaerobic, which is a non-selective medium to cultivate any fastidious and non-fastidious organisms with essential growth components and determine their hemolytic factors while considering their aerobic conditions. McConkey agar is selective to isolate gram-negative bacilli and differential for lactose and non-lactose fermentative organisms, where lactose fermentative will turn pink and non-lactose fermentative will turn yellow. Similarly, nose swab was cultured on horseblood agar, aerobic and anaerobic, and McConkey agar. Blood sample was cultured in 2 bottles, aerobic and anaerobic. Expected results on day 1 for wound swab. We saw equal growth of gamma hemolytic colonies on both the aerobic and anaerobic, lactose fermentative pink colonies on MAC, gram-negative short and straight rods, catalase positive, oxidase negative, all of which indicate an enterobacteriaceae, which is why we performed an API 20E. After incubation, the API 20E, as we can see, positive for MPG, which confirms the lactose fermentation on the MAC and the fermentation of most sugars on the right. For the nose swab culture results, we would see beta hemolysis on around paint-drop-shaped colonies on aerobic HbA and just about the same amount on the anaerobic. No growth on MAC, gram-positive cocci, which look like perfect spheres, catalase positive, indicating a staph species, which is why we performed a coagulase test to differentiate between Staph aureus and other staph. This came positive with coagulation clumping as seen. Then, to confirm Staph aureus existence, we performed DNase test. On day 2, DNase test came positive on the agar seen as A, in comparison to the B positive control and C the negative control. This confirms how Staph aureus hydrolyzes DNA and uses it as a source of carbon and energy for its growth. After 2 days of incubation, the blood cultures came positive and were cultured. From the positive anaerobic, we eventually processed to identify it via API-20A and found the strict anaerobe is Bacterius fragilis, while API-20E identified the facultative anaerobe as E. coli.
We first began looking at the clinical notes of the patient to try and determine which pathogen may have caused the growth of pus on the surgery wound. It was suspected that a Staphylococcus species, Streptococcus species, or E. coli may have caused this infection, as they are the most common causes of infection post-operation. However, the surgery was performed in the abdomen, so we also suspected Bacteroid species to possibly be present, as it is often found in co-infections with facultative anaerobes after intestinal surgeries. So due to these facts, the media we set up on day 0 support the requirements to grow our suspected pathogen of the wound swab we received. On day 1, a pure culture of a non-fastidious lactose-fermenting short straight gram-negative rod that was catalase positive and oxidase negative had grown. And these results conclude that the causing pathogen is an Enterobacteriaceae, so an API-20E was set up to further identify the pathogen. After 20 hours, it was determined that the causing pathogen of the wound infection was E. coli. There is a possibility that bloodstream infections may occur after surgery, so a blood culture test was set up to check if the patient had a presence of bacteremia. This test is extremely important as bacteremia must be treated with antibiotics immediately. If not, it may lead to sepsis, a potentially life-threatening condition. And after 2 days, the results were shown to be positive as a mixed growth of bacteria, which were later identified as Bacteroides fragilis and E. coli were present in the patient's bloodstream. Being normal gut flora, the open wounds during surgery allowed these organisms to easily displace into the bloodstream of the patient. And lastly, we also received a nose swab specimen to test if the patient is a potential carrier of MRSA. This may not necessarily cause an infection to the patient, but it is important to know who a carrier is in a recovery ward, as MRSA poses as an extremely high threat to recovering and immunocompromised patients.
So, one of the 3 different types of bacteria inspected in this investigation is E. coli, which is an anaerobic gram-negative rod that belongs to a wide range of bacteria that may cause various infections and diseases, including pneumonia, UTI, and surgical wound infections. In fact, it's the 4th most common pathogen implicated in surgical wound infections. This bacterium is typically found in the gut of warm-blooded organisms, and many of the strains belong to the normal human flora, meaning that they do not cause any harm to the human body. However, some harmful strains produce toxins that can cause serious illnesses. Infections caused by E. coli are typically caused by inadequate hygiene, consumption of contaminated food and water, as well as contact with infected animals. There are different pathogenic strains of E. coli that can be divided into 2 groups, including invasive and non-invasive, where each one causes different symptoms and levels of infection. On the left-hand side, the strains that attach but do not invade include enterotoxigenic E. coli and enteroaggregative E. coli. On the right-hand side, 3 other main strains that are invasive include enteropathogenic E. coli, enteroinvasive E. coli, and enterohemorrhagic E. coli. Bacteroides fragilis is a gram-negative, non-spore-forming obligate anaerobe that is part of the normal human flora of the human colon and cause infections such as meningitis and septic arthritis, as well as clinical infections such as surgical wound infections. These infections result from surgery, any underlying disease such as diabetes or trauma. MRSA, also known as methicillin-resistant Staphylococcus aureus, is a Staphylococcus aureus bacterium that is resistant to antibiotics. It is a bacterium that commonly lives on the skin, nose, or mouth and causes infections in different parts of the human body. These infections typically occur in people who have been in healthcare settings or hospitals who undergo invasive procedures such as surgery. Other infections caused by this bacterium include skin infections and pneumonia.
Both E. coli as well as B. fragilis are normal gut flora, but due to the abdominal surgery they found their way into the blood. In order to allow the doctor to have as much information as possible for a course of treatment, we will need to set up antibiotic sensitivity plates. That way, the doctor will have the information needed to make an accurate decision on what antibiotic treatment will be best suited to the patient. This sensitivity plate will need to be done for both the pure culture of E. coli as well as the B. fragilis. Beta-lactamase as well as AMC plates will be set up in order to make sure that the right antibiotic is administered to the patient. This can be achieved for the E. coli via multiple tests. In most clinical settings, we use the E. coli ATCC25922 as a wild-type quality control strain, with the indicators cephalosporins, clefalotaxamine, or clefidime will be used. Biomerix has also developed an easable e-test that is used in various laboratories, and these are the more conventional methods of detection. Newer, more rapid methods of detection, such as MALDI-TOF MS, have been proposed. This method of testing is effective since it has the ability to test direct blood samples, so no time needs to be wasted on producing pure cultures. Automated methods, such as Microscram Walkway 96 system, was produced by Dave Bering, or Baramex's VTEC 2 SBL test has also become options for clinical use. These methods do have a degree of inaccuracy, so they are best when coupled with conventional methods of analysis. Real-time PCR has also proven to be convenient and relied upon method for typing E. coli as well as B. fragilis. So, now that we've identified the organisms and the best course of action to relieve the patient of them, do we need to report them? In regards to reporting these pathogens, we need to follow the rules outlined in the UCAST Expert Rules in Antimicrobial Susceptibility Testing 2016 version. There is a review underway for these rules, and until it is completed, the UCAST Expert Rules version 2 is considered valid. Once we've done the susceptibility tests, we can then determine via these rules if we need to report them or not.
To summarise everything up, our patient is a 52-year-old woman in the recovery ward due to abdominal surgery. We received 3 specimens, a wound swab with pus, blood and a nose swab. We were able to identify the pure culture of E. coli from the wound swab via techniques of selective and differential media and biochemical tests. A blood culture was performed to check if the patient had a presence of bacteremia to prevent sepsis or any other serious complications. It was found that a mixed growth of Bacteroides fragilis and E. coli were present in her bloodstream. A nose swab was also performed to check if the patient was a carrier of MRSA, as she poses a threat to other recovering and or immunocompromised patients. The patient is a carrier of MRSA, so she may be isolated to reduce the risk of contamination. Further testing of antibiotic sensitivity plates for Bacteroides fragilis and E. coli are necessary to determine what antibiotic treatment will be best suited to treat both wound infection and bacteremia for the patient. Overall, none of these findings are serious complications, and the patient should be able to recover easily with the right antibiotics. None of these findings are notifiable conditions except for MRSA, and further sensitivity testing will need to be done to determine if it's notifiable.